Well, hi everybody. Get my box out of the way here. So nice to see you all. I'll go ahead and share my screen and then we'll get started with the presentation. So hopefully everybody can see my screen share. So today I'm going to be talking to everybody about training future psychologists. And of course, we have at PSM, our APPIC member postdoctoral residency program. And my hope is really to kind of make this talk broad enough so that it speaks to just postdoctoral training at a kind of a bigger level, but then also to talk specifically about the PSM program and more as sort of an example, and obviously the one that I'm most familiar with being the training director here for our residency program. But I'll be talking more about just kind of training postdocs in a kind of a broader way so that we can talk, kind of big picture. But let me tell you a little bit about, what we're going to talk about today. So I'm going to start with an introduction to APPIC, which I'll talk more about their role in a moment. But this is the one of the kind of sort of accreditation bodies out there for postdoctoral residency programs. So talk a little bit about what they do, why they exist. And then I'm going to talk about just the requirements for training programs for residents and how this fits into kind of the larger trajectory of training that they've gone through, knowing, of course, this is the final training year that psychologists have before going to get licensed in whatever state they plan to practice in. I will also talk specifically about the Psychology Specialist of Maine postdoctoral training mission and model and how we are kind of fitting with the requirements for licensure in the state of Maine and fitting with the APPIC requirements, but also just a little more about kind of how we structure the program, what the goals are of the program, why we do things the way that we do. And then finally, I want to talk about supervision and just in that final year of training, how we approach supervision from a developmental perspective, the kinds of things that we expect to be talking about a lot in postdoc supervision. I'm glad that we have a number of our supervisors here on the call today too. So as we get, especially towards kind of later in the presentation, if people want to chime in with additional thoughts about just what supervision is like, again, in this final year of training, then I'll be happy to open up the discussion a bit more. And to that point, if people have questions really at any time through the presentation, I will pause. I'll try to be kind of mindful about pausing, but also just feel free to unmute yourself and come on, basically pipe up with any questions that you have. I realize I don't have a clock, so I'm going to put my All right. So I wanted to start with the Association of Psychology Postdoctoral and Internship Centers, or much easier, APPIC, as our kind of membership body that we have for postdoctoral and internship training. But I think for most of you, you're probably most familiar with the association, the American Psychological Association, or APA, and that's often known as sort of the accrediting body for particularly internship programs, though also for postdoctoral programs. So APPIC is another sort of membership body, or you could call it accreditation. They really term it more as membership. And their purpose is they are organizational. I'll talk about some of the things that they organize, but they're really a resource for programs and for trainees. And then they're also a membership association, so for both predoctoral internships and postdoctoral residencies. So they coordinate quite a bit with APA, but they are not the same. They're not sort of officially affiliated with APA. Some of the things that they are best known for include the National Match Program for internship sites. So this began in 1999. I was actually reflecting today as I was getting ready, and I thought, gosh, it's been 10 years just over 10 years since my internship match day. So that is, yeah, a day that I think many of us probably have blocked because of just the sheer amount of anxiety that went into that. But they are the creators of the National Match Program for Internship Sites. This is based fairly similarly to the MD model for matching to residency programs, but basically this idea of kind of, sort of rank ordering your internship programs. The internship programs rank order their applicants, and then a nice kind of computer algorithm goes in and maximizes everybody, and you just get matched and you have to go there for a year of your life. So lots of anxiety around that. That's been around since 1999. I was looking on their website for when it was sort of universally adopted. Nowadays, just about every internship program uses this system, especially all the APA accredited ones. And I don't think it was 1999 when that began, but soon afterwards, certainly people started using that more and more. They also manage the Universal Psychology Postdoctoral Directory. And they have an internship version of this as well. But for the UPPD, that's really postdoctoral residency programs. And this is a great way for applicants to just see all sorts of, really what's out there in terms of postdoc programs. So you do not have to be affiliated with APPIC in any way to post your postdoc program on the UPPD. So if you can, it's actually kind of fun, you can go in and to appic.org and look at their listing of all the postdoc programs that are in the US. And I think they might do Canada actually too, now that I think about it. So a great way to sort of structure your search. And we've been listed on the UPPD now for 5 years, even though we haven't been an APPIC member for that long. And then the other kind of big thing that they do is they, for postdoc programs, have been promoting a commitment to what's known as a uniform notification date, or UND. This has been a really big part of their recent work, because it used to be the case, it still is, and for most programs, that you can, for applicants, they can be applying to all sorts of postdoc programs, but programs, much like a job, they can sort of give an offer at any time. So then it would put residents in this really challenging position of maybe getting an offer at their maybe second choice program, and they still haven't even interviewed at their first choice program yet. So then they're sort of being forced to make a choice without knowing whether they're going to get a reciprocal offer from their first choice program. So February, I think it was the 22nd this year, usually it's sometime in that kind of third week of February, is the uniform notification date. And APPIC's really urging all postdoc programs to hold off giving offers until that date. So then resident or future residents, trainees don't have to kind of be like sort of, trying to hold an offer, waiting for another one, all of that. And then the big one, certainly, that we've been at PSM very excited to be a part of, is their membership status. So APPIC does have a sort of accreditation program where they put out kind of minimum training standards, and you can basically submit an application for just describing your program. And if your program meets and exceeds those training standards, then you sort of get that status of being a member for APPIC. And I'll talk a little bit more about what those requirements are in a moment. So residency requirements, of course, vary by state, as everything seems to do. In the US, every state has its own idea for what kind of needs to be happening during a postdoctoral residency year. I will say that does make it, I think, pretty challenging for trainees, because they might get might get their postdoctoral training in one state, but then plan to actually practice in a different state. And so I'm often talking to our residents about, okay, where do you want to get licensed? Because you should be looking now to see, what are the requirements? Some states, for example, require like 2,000 hours of postdoctoral residency training. As you can see, the state of Maine only requires 1,500. And so wanting to make sure that whatever training program they're applying to kind of meets the minimum requirements for the state that they want to be practicing in. So anyway, I'll go over the state of Maine requirements since, of course, I think most, if not all of us, are licensed in or planning to be licensed in the state of Maine. And then I'll talk a little bit about how that differs from APPIC. So state of Maine, you have to accrue 1,500 total postdoctoral training hours. It has to be obtained in at least 48 weeks, but no more than 104. So there's sort of this 1 to 2 year window where you can get your hours. At least 25% of those hours have to be in direct clinical service. So these are kind of client-facing hours, but not more than 60%. So there's some nice kind of protections in there, honestly, I think, for residents kind of signing up for something and then being just, seeing like 40, clinical hours a week or something like that. They have to get at least 1 hour of individual supervision per work and at least 1 hour of what they call additional learning activities. And that can be really anything. It can be things like self-study on maybe a certain form of therapy. It can be participating in training series. It can be things like teaching activities. So I know, like, when I applied for licensure in the state of Maine, a good number of my hours were in teaching and research, because I was doing a research postdoc. So all my research hours applied into those additional learning activities, which I was doing many more than 1 per week, right? So you kind of obviously have to fill in your 40-hour week more or less. So state of Maine's requirements are actually on the lower side compared to many states. That said, I should say there are some states that require no postdoctoral residency. So we could say those are, I suppose, the lowest requirements that are out there. But the state of Maine does require postdoctoral residency hours, and they're on the lower side. APPIC has some overlap with the state of Maine. So APPIC says in order to be a member program, you also have to have at least 1,500 hours over 1 to 2 years. And, it's interesting, 1,500 being so low, we really decided to just go for what would be essentially a full-time position, or just under full-time, which is 1,800. So the PSM program requires 1,800 total hours over the course of the year. And that'll get you licensed in most states out there. So there are some states, like I said, that are 2,000. And if that's the case, we'll work with a resident just to make sure they get the hours that they need for that. So at least 25% of the hours have to be in what they call professional psychological services. These are essentially face-to-face hours with clients. You'll notice twice the number of individual supervision hours. So according to the APPIC membership model, you need to have at least 2 hours of individual supervision. This is not group supervision. So anybody who's doing kind of group supervision with multiple residents, that would be additional to those individual supervision hours. And then at least 2 hours of additional learning activities per week, which is essentially the same as Maine. What really differentiates APPIC membership is this last bullet point. And I think this is helpful because, something that's interesting, unlike internships, so, people go through 4, 5, 6 years of their doctoral program, they have this, 1 internship year where, usually it is a very structured training program, right? So you're applying to an APA accredited internship program that maybe you have a small cohort or even a large cohort of other interns. There's lots of supervision, there's lots of training, it's very programmed. Then a lot of people end up going to, especially if they want to do clinically focused career, what is almost more like an apprenticeship for their postdoc year. Maybe they're going and working at a hospital or an outpatient clinic or something where they're really just kind of one of the staff, right? Maybe they're also having to get supervision, but they're operating pretty much as sort of a staff member and doing all the kind of things that any other staff member might do, like an apprentice would, kind of maybe following all along and shadowing and consulting more supervision. But APPIC really is saying, in order to be a member program, you need to have this planned program sequence of supervised training experiences. So much more like what you would see on internship, where there are clear goals and objectives, that there's a sort of idea of, what's the arc of this training year going to look like? How are the training experiences going to build on each other? So not just kind of scattershot, attend a couple of different trainings, but like, okay, let's sort of think about, where you're coming in and where we want you to be by the end of the year. There has to be sufficient qualified training staff. So in your application for membership, for example, you have to list who's on sort of the training faculty. So here at PSM, that's mostly the kind of full-time staff members also are on our kind of clinical faculty. There need to be documented procedures for resident evaluation. So quarterly is what they require. Quarterly, basically prompts for giving feedback. So I'll show you a little bit later, we have a rating scale system that both the residents do for their supervisors and the supervisors do for their residents. So to prompt that discussion, we need to have a grievance policy. So if there's ever a situation where a resident kind of wasn't keeping up in the way we would expect them to, we would sort of start this grievance procedure, and they need to also have an ability to basically provide a sort of a rebuttal to the grievance and kind of work through that. There have to be certain admission requirements. So to be an APPIC member program, you have to require your residents to have either an APA or the Canadian PA accredited graduate and internship background in order to apply and qualify. And importantly, you have to have sufficient financial resources to support the program and provide a fair and reasonable stipend. And that's important to APPIC. They want to know how much you're paying your residents, so you're not kind of doing some sort of a very low wage labor situation. So in the end, as I have in the box here, I think really that APPIC membership both protects the residents and also benefits the program. So, I think if a resident is applying to an APPIC member program, they know that there is, especially this last section on the slide, that planned program sequence of supervised training experiences. So they're going to have something that is well thought out. And that has not just been thought out by maybe one person, but actually has passed through the APPIC board to say like, yes, we can see kind of where your program is. So it protects the residents. It also, and this I can speak a little bit more to, provides a lot of informational and mentoring resources to programs. So for example, this past year, I got paired with an APPIC mentor, somebody who'd been a training director for many, many years to a VA program. And she was really great to talk to as I was kind of explaining sort of the way that our program is focused and how I wanted to kind of build it a little bit more, and also get the word out about our program, being up here in Maine and not part of the VA system, for example, we can fly under the radar a little bit. So she and I met a couple of times to just talk about program development and things that can be really appealing to residents when they're or interns, I should say, when they're applying to residency programs. And then they also do things like have CE trainings for training directors, things like that. So lots of just resources available, which is obviously very helpful. Let me pause here for a moment. Any questions so far on the structure or requirements for residency programs? And people can also use the chat if they have questions. Okay. So moving forward, I want to talk a little bit about PSM broadly before I focus in on our training program specifically. Something that certainly appealed to me when I came to work at Psychology Specialist of Maine, and I think for many of us this is appealing, is the just really directly stated commitment to growth, to learning. It's in the mission statement, right? Our mission is to learn. First thing, grow, lead, inspire others to live themselves and live to their fullest potential. And of course, we think about this a lot with the clients that we see and the work that we're doing with them. But we also think about it with ourselves, kind of our continued commitment to training, growing, and just sort of being our best in our clinical work, but also personally. And I think it's so easy to just bring the postdoctoral training program right in under this mission, right? So learning, growing, leading, inspiring others to believe in themselves. That's a big part of what we like to do in our residency program as well. So I won't go through all of the vision and values here. Hopefully this is familiar to people. This is on our website. But, really kind of, for the residents, I think thinking about their strengths, what is it, at this point, they've been doing therapy for at least 5, 6, 8 or more years by the time they come to us. So they already have a lot of strengths, but then trying to see, okay, what's the growth that they have that they still want to build? What is it that they're wanting to learn more about? And then also really integrating people into our team, so they have that sort of belonging and the relationships for support, whether that's, maybe mostly with their supervisor or with their cohort of other trainees, but also hopefully the practice on a bigger level. So right from that comes our program aims and training objectives. So these are some of those things that we initially submitted to APPIC when we're applying for membership. So our first program aim is to train competent and skilled generalists who will be fully prepared to succeed in their independent practice. And I think, a lot of the residents that come to our program are looking for that group experience of being part of a group of practitioners. And maybe they're planning to continue in that kind of group outpatient setting, or they might be interested in doing private practice by themselves. So either way, we're hoping that the training experiences that they have with us prepare them for, either of those tracks, or also things like, counseling centers and other sort of outpatient models that are out there. Then number 2, and this one I will speak a little bit more on as we go into the supervision piece as well, but we really are trying to encourage development of our residents' therapist identity and really thinking on how that overlaps with their personal identity in other contexts. So thinking about, what kind of therapeutic services do they really like to provide, and how does that maybe fit with them personally, that sort of thing. And we do a lot of just professional mentoring, like, okay, what are the kinds of settings you could see yourself working in the long term, and how does that really fit with you? And then finally, the nuts and bolts of what we do as therapists. So developing a lot of confidence in assessment and intervention. We have as you all know, a team of very skilled therapists here who are also our supervisors, and who really know evidence-based treatment approaches and modalities that then we can give further training to for our residents. So we have here our kind of years of being a postdoctoral training program. So I wanted to just overview where we've come from, and I don't know exactly where we're going, but maybe some ideas of what might be coming up in future years. So our very first year as a training program, we had 1 full-time resident. And we did that year post on the UPPD and get that resident through our posting there. And I think our sort of spiel was, okay, it was me and Julie mostly doing the kind of push here. So we're like, okay, we can provide EFT couples therapy training, we can provide DBT skills group co-leading, and those are going to be kind of the anchor points of the training year. And so we're really looking for somebody who is interested in just working with emotion, I suppose you could say, in therapy, which is probably many, if not most kind of therapists out there. And we found somebody who really was excited about both the EFT and the DBT experiences that we were offering. We learned a lot that first year about just, I would say we were very much more that kind of apprenticeship model at the time. We didn't have a lot of like focused didactic training stuff that we were doing. It was more like, okay, this is what we're doing, and why don't you come along and kind of learn from us. And obviously doing the individual supervision, both with Julie and with me. The year after that, I kind of omitted from my chart here because we had a resident, it was McKay, but she was coming in with she'd already done a postdoctoral training year, and so her needs are a little bit different. So year two, official year two, really was, we had 2 full-time and 2 part-time residents that year, a great group of 4, all of whom are still working with us here at PSM. And that was really, I think, our first year of thinking more through like, what's our structure? What's our where are people coming in, with some variability? And then where do we hope they'll be by the end of that training year? And what do we need to give them, over that time to kind of help scaffold that process? So we added really a big focus on didactics. So we had monthly 1-hour meetings on things like, or actually many multiple months, we had sort of every Monday a meeting on something. So professional development, a group therapy series. They joined our lunch and learns like you are all doing currently right now. So much more structure, still the EFT and DBT experiences in there. And then we, in our 3rd year, really revised that didactic even further. So I think we, learned a lot in year 2 about kind of what makes a didactic experience valuable, and that some things need more than an hour, for example. So we have year 3, which is our current year. We've been doing like deeper dives into certain professional development topics, and really allowing for like a full Friday afternoon to really kind of talk through something, and then changing some of the other didactics to reflect the kind of shift there. Next year, we have 4 full-time residents who will be joining us in September. And this has probably been our biggest restructure yet. We now have these 3 training tracks that we are recruiting for. So we have an ADHD, an EFT, and a DBT training track that we have posted separately on the UPPD, so people can see that we have these 3 different tracks. And we've got 1 ADHD resident, 3 EFT residents. I couldn't get anybody to do DBT with me. I think I gotta like be a little more be a little less scary maybe in the description on the UPPD or something. But ultimately, hopefully we'll have, over the next few years, kind of people circling through each of these training tracks. And I'll talk more about what these tracks entail a little bit later, but this really, I think, invites trainees to think about, okay, if I want to come out of my last training year with a particular sort of a specialization, right? Something that I can put on maybe my future website and say, this is one of the things I'm really skilled in. What do they want that to be? And then they can dive into that even deeper. Years 5 and beyond, I don't know what's going to come up for us in future years. I think I put on here sort of what our process is. So each year we like to, Julie and I, kind of sit and talk about what worked well. And I should say, Julie and I are doing a lot of the work in this, but also we're talking to the supervisors and people who are providing trainings and things, just to make sure we're kind of hearing from everybody on the faculty side. But also we're talking a lot to the residents and just hearing. I like to ask a lot about like what did you like? What maybe did you need more of halfway through the year? How are you feeling? What do you feel like you're kind of missing? So, just improving each year, trying to make sure, based on our observations and also resident feedback, that we are, kind of continuing to fine tune where we focus our time in the program. We obtained APPIC membership kind of going into the 3rd, our current year. So that's when we kind of went through the process to become an APPIC member program.
Do you have to report outcome data for that application, or is it just the sort of planning?
Yeah, that's a good question. We do. So every year I go in and update how many residents we had. And I think you have to do a little bit of, I know you have to do kind of where are they now, right? Like what settings are people in currently, which is certainly easy at this point because I'm in touch with all of our kind of graduated residents, many of which are sitting on the call right now. So I know exactly where they are and what they're doing. But yeah, I suppose over time I'll have to kind of maybe put together like a form for people to fill out or something. But yeah, so we want to, we do have to just show that people are basically progressing successfully through the program. Any other questions so far? Okay. So we'll talk about the program overview for this coming year. So this is going to be for our newly unveiled training track model starting in September. And still, a lot of what we're doing is similar to, in terms of just general experiences, what we have for our current postdocs and what we had for last year's postdocs, in large part because, you know, we still have our core group of training faculty who have their particular areas of specialization. But I like to think about what are the clinical experiences and what are the didactic training experiences that our residents are going to get over the course of the training year. So in terms of clinical experiences, core training, every resident that comes in is going to get a lot of training in individual therapy. And that comes back to who we are at PSM. You know, we are a generalist clinic that sees people with a wide range of presenting concerns. And when our residents go out into their their sort of early career psychologist phase, chances are pretty good they're going to be in a similar setting where you might do some referring out, but a lot of what we do is who we sort of see coming into our office, that's who we're working with. So lots of gaining confidence in just general individual therapy. And I'll jump down a bullet point to teletherapy. That's become, I think, especially in Maine, something that we'll always be doing. Whenever we're working in a state that has maybe rural kind of access issues, I think in particular, teletherapy is a great service to be able to offer. And so even though we hope to have more and more in-office services that we're able to provide again, the pandemic really prompted us to think a lot about teletherapy, and all of our residents will have that experience. And then there's going to be the track-specific supervision. So all of our residents have 2 supervisors. One of them is in their training track. So they're going to have someone who specializes in ADHD, DBT, or EFT as their kind of primary supervisor for anything going on in that area. So any of the clients they're seeing with those sort of focuses to their treatment. And then we have this individual therapy specialization opportunity. So a time for, actually probably in a month or so, I'll be emailing our residents for next year and asking them about their supervisor preferences. And I sent out a list of who we have to offer individual supervision. And this is going to be for anybody on their caseload who's not falling into their training track area, is going to be supervised by another individual supervisor. And, the specializations that are on there, those are the specializations essentially that we offer on our training staff or our training faculty. So, lots of potential experience in empirically supported treatments for trauma, psychodynamic, emotionally focused, and interpersonal approaches, CBT, DBT, ACT, and mindfulness and mind-body interventions. So somebody our residents can look at those areas of specialization and know that they'll be supervised somebody who's a generalist and who can supervise in just about any case they're going to see. And then maybe also an opportunity to dive a little bit more into a particular form of therapy. So we've got those clinical experiences, and then we really, I think, also pride ourselves in the didactic training that we offer. And so We have lots of opportunities throughout the year to gain more knowledge about various clinical skills. So, those clinical training seminars that Lauren so wonderfully puts effort into sort of setting up, half day and day long clinical training seminars that many of us also attend. Our postdocs will be attending those too. And then just track specific learning experiences. So each of the tracks has maybe, it kind of depends on the track, like a monthly meeting that people are attending, or self-study, maybe video or readings that they're doing. So lots of opportunity to learn more on the training side. And then peer and all practice consultation meetings. So they're attending, the Friday consultation groups, for example. And then the professional development side, so lunch and learn training series like this one, of course, we're asking our residents to attend these, and then also their own professional development seminar series. This has been really great. I think this year in particular, like I said, we've extended the time on those. So it's going to be like a 2.5 hour discussion with one of our core staff, who's going to be talking through some kind of professional topic. And it can be things like, certainly looking ahead and, planning your future career, but also a lot of the just stuff that we do now and have to do always as therapists around. Maybe it's like I gave one on managing crises and assessing for suicidal risk, things like that can just be probably always helpful to be learning more about. To give a little more detail about the specialty training tracks, so here is the kind of brief overview of the training experiences that go along with each of the tracks that we're offering. So I won't review every single bullet point here, but basically we've got, the ADHD track, a nice mix of doing evaluations. So we get a lot of, psychodiagnostic interview sort of experiences here, writing reports to summarize findings and discussing those with the clients that are presenting for evaluation, but also opportunity to gain experience in treating ADHD in therapy, both through individual and group therapy. For the DBT training track, this is going to be really the experience of doing the full kind of comprehensive DBT model. So individual therapy with telephone coaching, skills group, so co-leading skills groups, and then participating as well in the DBT consultation team. And ideally, hopefully, obtaining the hours that would be required for actually getting the certification in DBT if they choose to do that. And then EFT is going to be obviously a lot of couples, mostly kind of couples focused. So taking couples over the course of the year, as well as doing the EFT workshops. So the kind of date nights or full weekend workshops that Julie runs. And really learning that EFT model. This one has a lot of didactics to it, especially being for some residents kind of maybe even the first time they're seeing a couple in therapy. So there's a little bit of a heavier didactic load here with self-study and meetings to discuss the model. Before I go into talking about supervision, anybody have questions or comments about the PSM program or anything they wanted to talk about a little bit more?
Hi, Kate. It's Julie.
Oh, Julie, you're here.
I just wanted to say you're doing great and I'm here.
Oh, thanks.
So I got your back if you need me. I'll say a few
Cool.
things at the end, but.
Okay, sounds good. Let's talk a bit about supervision then. I was feeling very botanical when I made this, this presentation, so it was very growth oriented. So I think by the time our residents come to us, they're probably a little bigger than the sprout on this screen here, right? So like I said, they've been doing actually years and years of therapy before they come to us as residents. I like to remember that because it just sort of, well, I'll talk about the integrative developmental model supervision in a moment, but it's important, I think, to remember that, unlike supervising somebody who's maybe a graduate student, for example, when I've supervised graduate students, there's a lot more, kind of this like little sprout, right? Trying to sort of figure out like, what am I doing here? What are the things, what are the tasks that I have in front of me as a therapist? How do I help people change? Even like just that experience of working through a case and seeing somebody change over time. When you're early on in your therapy learning experience, I remember learning therapy and being like, wow, I got a lot of people that I need to help. And so far, nobody's gotten any better. Like, I don't even know what it looks like when somebody sort of improves in therapy. By the time they're coming to us now as a postdoctoral resident, they've worked through a lot of that. They have a lot of more experience in sort of, what is my role here? What do I need to do? And also knowing that people can improve. So, which is lovely. It means we can really focus on, okay, what are the final year of structured training before getting licensed? What do you have left on your plate? What are the things that you want to maybe grow in a little bit more and learn? So there's lots of nice writing on this. I'm just going to present very briefly on the integrated developmental model of supervision, or IDM, because I think this kind of very nicely shows where residents often are when they come to this final year of training. So if we think about those early therapy experiences as your level one, naive awareness. And I love, they talk about Stoltenberg and et al. The self-focus, like you're sitting in the room trying to help this person, but most of the time, a lot of our thought is very self-conscious. Like, what do I say? Oh no, what's the next thing that I'm going to do? High anxiety, also a lot of motivation. I remember being a graduate student and people would laugh. I had the DSM just, on my bedside table, and most nights before bed, I'd just flip through and read some DSM. And I will admit I have some DBT books currently on my bedside table, but I have a lot less motivation to flip through them because my anxiety is a lot lower. Anxiety can be a helpful motivator, of course. Naive awareness is that early level. Level two, confusion. Like, I know enough about what I'm doing, but not enough to feel confident in it. So a lot of kind of fluctuating confidence and autonomy, but increasingly being able to focus on, okay, what's going on with the client in the room. And then level three, calm after the storm. Much more of that kind of sense of calm maybe in the therapist. They know what their task is. They know what they need to do. They've seen a lot more in therapy, and are much more able to integrate that self and client awareness together when they're in the room. And then there's sort of this level 3I, which is like once they're integrated across all treatment domains, maybe assessment and intake, individual therapy, maybe you're in groups or couples or whatever. I would say a lot of our residents come in essentially on their way to or in level 3, which is just kind of cool, right? They've been through a lot and they've kind of figured out more or less like, okay, these are maybe the kinds of therapy I like to do. I know how to do them. Even like when residents first come in, I do a sort of orientation day. And one of the things we talk about is intakes. Okay, you're about to get a lot of intakes in your schedule. They're all nodding. They know what to do in an intake, right? I don't have to talk through, okay, here's some questions you might want to ask, and here's how to write an intake report. And over the course of the year, I think we throw them into level 2 a fair amount, sometimes even level 1, usually with those new training experiences. Like, when we have residents coming in who want to learn EFT for couples, and maybe they've only seen 1 or 2 couples in their, previous work, or maybe none, that's very common too. So, level 2 confusion, right? Like, I know how to sit in the room. I know how to maybe kind of make validating comments and be an active listener. I even know about attachment theory, but now I've got this new model that I'm really trying. So that level 2 confusion, that sort of fluctuating confidence, and maybe relying a lot of the times kind of more on the supervisor. What do I do, right? This happened in therapy. What do I do next? So I think there's even a little bit of just gosh, some anxiety even that comes from, oh, I thought I was, level 3, I thought I made it, and it's just, place with some confidence, but then taking on some training experiences that maybe knock people back down again. And of course, I mean, that happens throughout our career. Anytime we're trying to learn something a little bit new, but certainly in this final training year, supervised experience, it's a great opportunity maybe to sort of knock yourself down to level 2 and build back up again. Tracking areas of competency. So like I mentioned earlier, one of the APPIC requirements is that we need to quarterly provide evaluations to our residents. It's not required, but we also require our residents to provide feedback to their supervisors too, just to make sure that supervision is also kind of meeting the needs of where the residents are at and to invite that conversation. But for residents, supervisors are providing evaluations using this rating scale that I have on the slide in 5 different domains. So assessment, that can be things like mostly diagnostic assessment at the beginning of therapy, but also if they're doing maybe additional evaluations. Intervention, and this is going to be individual couples and groups depending on what their training experience is. Ethical and legal standards, individual and cultural diversity, and then professional and communication skills. And we've got a number of kind of sub items to all of these areas. I want to just highlight the rating scale. I like this rating scale a lot. So a lot of people come in the sort of 2-3 range on most of these items. So maybe there's some, again, kind of growth areas where they're needing fairly routine supervision. I think again about maybe someone who hasn't seen couples and is coming in to do couples work. Like you should be in a 2, right? This is going to be a new area. But then, increasingly over the training year, coming into that 3, and by the end, many 4s kind of on the training or on the evaluation scale, so that people are essentially leaving our year as we hope they would be ready for independent practice. So I wanted to just summarize some of the primary themes that we see in supervision. So some of this I think I've touched on, but lots of just work with confidence, and particularly confidence in professional identity. So, what kind of therapist do you want to be? What are the things that you want in terms of maybe your personal style in therapy, the sort of areas of expertise that you offer, and what your clinical interests are. And then lots of confidence just working with a range of cases, so that you maybe have your area of specialization, but also have comfort as a generalist. The second bullet point is a big one, especially for those training tracks. So, many of our residents are coming in with a base of knowledge that maybe made them think they want to work more with DBT, for example. Maybe they've had some CBT, or done some mindfulness. So they have some of the building blocks, some existing knowledge and clinical skill, but then, building further, right? So learning a model that builds on that so that they can really apply it with confidence. Navigating common outpatient setting, ethical and legal scenarios. I should add into that really things like, maybe boundary setting or other kind of, professional limit scenarios. So lots of work with that. Professional mentoring generally. So I think many of our supervisors will talk with their supervisees about, where do you want to go with your career? And maybe this is what my story was, and, kind of giving some examples of where people come from and how they get to, different places in the very wide career path that's out there for psychologists. But generally overall in supervision, we're moving really away from supervising and more towards kind of consulting like a peer. So by the end of that training year, I find that my supervision feels a lot more like this kind of consultation meeting, one-on-one, because you're supervising somebody who has a lot of clinical knowledge by that time. I included a few testimonials in here. These are some just things that our past residents have written about their experience at PSM. And what I love about them, in addition to, of course, it's great to see when people have a positive experience, is really what we're going for, especially coming off of that last slide of, final training year, right? So people are coming in with a lot of knowledge and a lot of clinical skills. So as you can see, all of our testimonials here mention, what it feels like to be an independent clinician, or the expertise and agency of each of its residents, utilizing my strengths, right? So kind of showing our residents, you do know a lot, and we want to kind of emphasize and build on that confidence, while also, maybe stretching a little bit, gaining specialized training, kind of gaining areas of expertise that maybe they, again, had the building blocks for, but are now putting into use in a very particular way. So both the sort of building of confidence in what is already there, and then the adding of new knowledge and new skill. So that's what I have for kind of the content for today. I think what I'll do is stop the share so everyone can see each other again. And then maybe, Julie, did you want to add anything or share anything? Oh, you are muted.
It's helpful if I'm not muted, I think. Let me go to
Indeed.
salary view. Thank you, Kate. Actually, that was fantastic. I'm so proud of the program we've developed. I wasn't here at the beginning. I'm deep in a couples intensive on my lunch break right now. So I like the kind of metaphor of being on the dance floor or having the balcony perspective. And I so appreciate with the postdoctoral residency, I both have that balcony perspective, and I'm really on the dance floor with the postdocs. But one of the reasons we actually started the postdoctoral residency at PSM was to honor, I think, one of our core identity as a group is scientist practitioner. And so having a growth-oriented learning culture was really important. And it's hard to do in a group practice because we are so focused on serving clients that it's hard to sort of bring in that kind of component of growth and learning. And so having a postdoctoral residency really supports our mission to have that be a constant in our group. So even with the brown bags and opportunity to teach didactics and supervision, and that's felt really good. And I think it's come into fruition, and I look forward to building on that more and more. And I would say the other thing is really this idea or aspirational goal of attracting more really well-trained psychologists to the state of Maine. I think it's recognized as one of the limitations that we're facing right now in terms of access to really good mental health treatment. And so I feel really good about that. And actually, including our postdocs this year, Tristan and Olivia, we have helped train 8 psychologists, and I'm proud to say all of them are still working with Maine clients. And we'll add 4 more to that group next year. So that's exciting and feels very purpose-driven in that way. So that's all I wanted to say, but yeah, thank you.
Thanks, Julie. Does anybody else have comments or questions?
Michelle's back on her deck. That looks lovely.
So amazing. Well, then maybe we can leave it here so people have a few minutes before their 1 o'clock appointments, unless, I don't know, Lauren, if you have more that you wanted to say as we wind down.
Nothing in particular. I'm sort of thinking, I guess maybe one thing is just noticing even, as I'm sort of learning about the person who's coming into my track, that it seems like there was this invitation, or I'm not sure how it happened, but essentially her already feeling comfortable even this early on in the process and sort of saying, here's the thing I want to do, this couples work for people with ADHD. It's a little different than what was initially set out. Like, is that possible? And it feels so good that it seems like we've given the vibe that people feel able to ask that so early on. And there is this willingness on our part, if that's within our capacity to make it happen for people. That just seems like what we want this to be like for folks who are coming here.
Yeah, I think that's definitely the case. And it's nice because actually I think one of the benefits of having these training tracks and the reason that we did it is it really emphasizes what we do, or we do a lot of things, right? But like these are some areas that you can really build on. And then I also, talk, actually, some of the slides from today's presentation are from the little kind of spiel that I give to residents, and I've recorded, it's on the website, to people who might be thinking about applying to us and seeing like, okay, what are the other things that we are good at here that you could potentially learn more about if you were to come here. So yeah, we try to give as much information as possible so that by the time somebody comes to even interview with us, hopefully they have a pretty good sense for us as a fit for them. And so it's been great, actually. I think that we don't end up having to sort of like weed out a lot of applicants. Many of the people who apply to us are, a good fit for a number of reasons and can have the information they need to ask for maybe particular training experiences that could be a good fit for them.
Lauren, what's on the docket for next month? I forgot.
Yeah. Oh, yeah. So next month it will be Karen Levine. She is a child psychologist, and she will be talking about something anxiety related in terms of child psychology. So I just was emailing with her this morning. So I'm very excited to have that. And in the coming months, we'll also have presentations from our couple of new folks who will be joining us. So yeah, lots to look forward to. I still have a couple of I think like one sort of open topic for next year, like next summer. So if folks have something that you're really hoping to see, let me know. But we've got a really good lineup over the next year or so.
And speaking of training leaders, both Olivia and Tristan will be sharing some of their expertise with us coming up this summer. So super excited about that. Olivia, your PMDD presentation? Yeah. Okay, yeah. And then I don't even know what Tristan's presenting on.
Yeah, I think you don't know because I don't know yet. I'm trying to decide what I'm an expert in, but it might be related to refugee, like asylum seeker, mental health. That's a possibility, yeah.
That'd be amazing. All right. Thank you.
Thanks, everybody. Bye.
Bye-bye.